practice patterns in the management of keratoconus. The first talk will be of Professor RADHIKA Tandon. She is not possible to join us in person because of her administrative duties. So her talk is a recorded version and it will be played on. She's going to speak to us on classification of keratoconus, the PENTACAM interpretations, refraction and contact lens pearls, and decision making in keratoconus. Can I request the audiovisual to please start the talk?
Thank you, Professor Vanity, for inviting me to participate in this instruction course. I'm going to take you through the classification, giving a few tips on PENTACAM and interpretation, as well as some practical pearls on refraction and contact lens fitting in keratoconus. In the interest of time, I shall be highlighting the main points and leading you to the correct sources for information. This is a summary slide of the main characteristics of keratoconus. Apart from the signs and symptoms, it's important to be aware about the known information regarding the etiopathogenesis, the various causes, and the pathology. This slide summarizes the main clinical features seen on slit lamp, illustrated by images taken from our clinic. Apart from hereditary features, there are known mechanical risk factors in keratoconus, particularly eye rubbing, which may be due to various causes. And knowledge of this is important not only for the doctor, but also communicating this information to the patient so that they can be cautioned to restrict eye rubbing, which is both important not only for the occurrence of keratoconus, but also contributes to progression, and even after treatment intervention, if eye rubbing continues, it can limit the outcomes. There are several excellent classification systems of keratoconus, and each has its role to play. In the current context of this instruction course, in present day times, I would like to highlight the ABCD classification described by Michael Bellin et al. It uses modern technology, essentially corneal tomography and Scheimpflug imaging criteria, separating the features in terms of A, the anterior surface, B, the back surface, C, the corneal thickness, and D also takes into account the best corrected distance visual acuity. And along with that, there is also the component of scarring, which is taken into account, so that for each patient you can customize the exact parameters and come to a more defined value of the stage of the disease. Continuing from the previous slide, this slide is summarizing the main criteria or the cutoff values which are useful for identifying the cornea at risk. These are largely used for screening patients for refractive surgery, because one would not like to operate with a corneal refractive procedure in a patient who has either got subclinical or is prone to keratoconus. It's very useful to have these criteria available handy near the PENTACAM machine or in the clinic. And just for an example, I would mention that in the sagittal map, it is not only one criteria which is taken into account. It is several of these factors which have to be screened, because there are patients who may have normal values for one or two parameters and abnormal for the other. So let's look at an example. This patient has keratometry values K1 and K2 within the normal range, and even the Kmax is below the cutoff. The thinnest spechometry is suspicious at 470 microns, but the maps do not show any remarkable changes of keratoconus. This is when the Bellin-Ambrosio enhanced ectasia display, known as the BAD display, comes into help, because with this display, the computer or the software excludes or deletes the data 2 millimeters, or you can set it to 3 millimeters around the thinnest point. The assumption is that this is the abnormal area, and excluding this from the calculation of the best fit sphere enhances the abnormality of the cornea in comparison. And it's very beautifully seen in this illustration how now we are seeing the red zone visible to show that there is an elevation anteriorly as well as posteriorly. And if you look at the corneal thickness spatial profile as well as the percentage thickness increase, here again one of them is showing within the range, a little on the higher side of the two standard range, and as you can see, the percentage thickness increase is dipping down below the 2 standard deviation limit. So this is definitely a suspicious cornea, and then now the software gives you nicely a D value and also a color-coded red flag to indicate that this is an abnormal cornea, likely to be keratoconus. So in concept, we have a spectrum of corneas. On one side you have normal, and at the other extreme you have keratoconus, and in between you have an area which is gray. It could be considered subclinical keratoconus, it could be keratoconus suspect, and within this it could either be a form-fruit keratoconus, which is like an arrested form of the disease, or it could be early keratoconus, which is subclinical now and with time may progress into a full-blown disease. Here is an example of a corneal variation where the anterior surface of the cornea is normal and the disease disorder is present on the back surface. So an irregular cornea leads to irregular refraction and there is poor prognosis for spectacles for vision correction. However, a contact lens, by regularizing the corneal surface and the irregularities, masks the problem and acts as a regular front refracting surface and can therefore give better vision in cases where spectacles are not useful. Just a quick word about refraction. The retinoscopy reflex is distorted, it may be swirling and scissoring, and there's a high amount of irregular myopic astigmatism, which leads to a challenge in deciding which reflex to neutralize. So this is difficult. It requires experience, practice, and time. An illustration, there's a patient with moderate and advanced keratoconus, bilaterally affected, using spectacles, but having troublesome glare and halos with driving and difficulty in face recognition. And with a contact lens, the patient was able to get full vision of 6x6 and was comfortable and was able to avoid surgery. These are the fitting parameters for the patient, and a quick word about the contact lens fitting philosophies. Apical clearance indicates a steep fit, and earlier this was taken as acceptable. However, it is known to lead to hypoxia and neovascularization due to lack of tear exchange. And apical bearing of the contact lens with a very flat fit can lead to apical scarring and should also be avoided. So for an optimal lens fit, there should be an optimal lens movement, about 1 to 2 millimeter movement with a blink, which facilitates proper tear exchange, and this can also be checked by looking at the peripheral pooling and indicative of the edge lift. Illustrating the importance of focusing on the edges as well. If using the first try lens, the parameter that one looks at is the lens diameter as well as the sagittal height of the cornea. Must evaluate the tear film, and one aims to have an ideal tear vault of about 150 to 250 microns at the highest point. So in a nutshell, the decision making, A, is to make the diagnosis, to arrest progression by early detection, and also avoid inadvertent weakening by corneal refractive procedures. And the borderline corneas can be quite challenging, and sometimes one can just follow them up and see what happens over time. Further decision making is which intervention and when to intervene to halt progression, and what is the best intervention to enhance or restore vision. I wish to emphasize here that there is a spectrum of disease from normal to abnormal, and high cylinder and steep corneas are red flags in any patient who comes for refraction or even a general checkup, and rapid progression. So these are the key factors. In addition, one would have patients who are achieving 6/6 but they're not satisfied. They have some sort of complaint that there is some overlapping, there is some shadowing, etc. So patients who are not easily corrected with refractive errors are the ones which come in the borderline category, and they require careful follow-up and careful evaluation. So the management of keratoconus starts with the making of the diagnosis, establishing progression, intervening, looking at the outcome of arresting the progression, taking the best decision for optimal visual rehabilitation, keeping in account the patient's requirements, the needs, and what is the best suitable option. Hello everyone, it's an honor and privilege to be participating in AIOC 2022, and I'm grateful to Professor Vanathy for